baby organization in a space that has been time immemorial, universal, and something that has impacted generations, cultures, all times, but seems to have become even more significant and even more relevant for all of us, especially thanks to the pandemic. The pandemic has brought home the idea of caregivers and caregiving to each one of us, irrespective of our age. Some time ago, one would think about caregiving as something that was fairly niche or something that would be an experience one would get either because of certain special circumstances, destiny, or perhaps a life stage. But here we are. But wherever we speak about illnesses, caregivers, or caregiving, very often it comes mixed with a lot of emotion, history, stories, and quite often the dreaded illness of cancer. We went, as we started our organization, we wanted to be able to initiate conversations and narratives around caregivers and caregiving. As you can imagine, a topic like this has a lot of connotations. It evokes emotions. It also triggers stories that one may have heard or not heard, and social norms that may have guided or informed who you should be, can be, can't be, etc. For example, I grew up in a home where it was absolutely the thing that you looked after anybody and everybody. The house was an open space for most people to come and visit. And I think that is true for most homes in India, where we treat our guests like gods. And they become a part of our social narrative. As time changes, as time progresses, the demands on us change. And the circumstances and the world that we live in is different today. It is certainly not the joint families. It is certainly not the kind of communities that we lived in until a couple of decades ago. So, what does caregivers and caregiving in today's world look like and feel like? So, caregiving in print and pictures is an endeavor to have conversations around the experiences of caregivers across the world. It is my dream that we will have many more stories of caregivers from India. But until then, we will bring to you many authors who have taken their heart out and written down their journeys and their stories and tried to help caregivers of today. Today is one such conversation, and the topic is caregiving for cancer, cancer caregiving, and how to keep your chin up. It has been on my mind for a few days about this conversation and what is it that I'm going to learn today. So, as I welcome Deborah Cornwall into this conversation. Hi, Deborah.
Hi, how are you?
I'm very well. I'm going to take a few more minutes to talk about Caregiver Sathi as an organization, introduce Deborah, and then hand you over to Deborah. All right. Many of you, I can see some familiar faces and many, many new faces. So it's lovely to have this large gathering. Caregiver Sathi. Sathi is the Indian word in many languages in India that means companion or a friend. So, a friend to a caregiver who walks along with you to navigate a caregiving journey that can be unpredictable, sometimes lonely, and sometimes challenging. So, Caregiver Sathi's aim is to empower family caregivers by creating an ecosystem of well being and healing for the primary caregiver when the caregiver and the patient are navigating terminal illness, chronic, or any other life limiting condition. Caregiving journeys are not just journeys that last while caregiving is on. There is much that goes on after the caregiving journey is over. So we would like to be the companions even beyond. How do we do this? We do this through awareness programs, webinars such as this, conversations with medical practitioners that we call humanizing our healers, um, conversations with caregivers, which we call conversations with gentle warriors. It is very important that we destigmatize the challenges that a caregiving journey can bring us. And we listen to sometimes difficult, sometimes victorious, and sometimes heart-rending stories of these gentle warriors. We also have a helpline to support those who may need information or help, healing circles or support groups during the caregiving journey or through love and loss sessions, um, research, curating articles, handbooks, materials, our podcasts, stuff which is available when you're registered on our website. So, those of you who are not registered, I'd encourage you to register on the website and access this plethora of information that is available. And finally, social media is the way for us to reach out and create awareness and sensitivity so that the cause of the caregiver, which tends to be invisibilized, is actually recognized, acknowledged, and appreciated. There are many resources that we have built so far, and we will continue to build them. And we invite you to join us as we build them. Whether it is a tech enabled website and an app, education programs which are delivered both online and offline, a community sensitization through a podcast, which is Caregiver Diaries, everyday mantras, and ongoing communication. Our flagship caregiver coaching and family counseling that after all, an illness impacts not just the patient, but the entire family. And we all need to perhaps understand our role and calibrate the emotions that long term illness can bring. My favorite, and I see that there are a large number of volunteers today, is the volunteer base that works relentlessly, gives us feedback, and helps us reach out to communities so that people, the youth especially, understand caregivers and caregiving. There are many ways in which you can get involved, whether it is through conversations, through spreading the word, being a volunteer with us, being an ambassador or a partner with us, working with us as an intern or fellow, participating in the support groups, helping us raise funds, collaborating as an organization or your school or college, participating in research, or certifying yourself to be a companion to a caregiver. With that background, it is my absolute delight to welcome Deborah and give an introduction to her. Deborah has been associated with the American Cancer Society and its Cancer Action Network as a volunteer leader since 1994. Wow. Serving in a variety of local, regional, and national roles and acting as a media spokesperson on multiple occasions. She was inspired to write her book, Things I Wish I Had Known: Cancer Caregivers Speak Out, by her interactions with cancer patients and caregivers in these settings. Her work is based on one-on-one confidential interviews with a broad sample of family caregivers from across USA. There are 120 patients ranged in the age of 2 to 90 and who experienced over 40 different types of cancers. The lessons from these experiences can be applied to many other kinds of caregiving. Other serious illnesses, various physical and mental disabilities, incapacity of elders, and so on. From that research, Cornwall shares the practical things that new caregivers need to know and interviews the emotional stories that led to interviewers' most important learnings. She's an alumni of Boston University and has about 35 years of experience in leadership assessment and development. She and I are professional colleagues in that way. Organizational assessment and development, board effectiveness and change, and has worked with senior executives at the interface of board of directors, senior leadership roles, mostly in healthcare and hospital leadership since 2001 with a particular focus on situations experiencing leadership, strategic, or organizational or culture change in a highly competitive marketplace. We should be having many, many conversations, Deborah. I can see that our conversations will go for many hours with so many points of intersection. Welcome.
Thank you. It's an honor to be with you.
Um, It is early morning where you are, and I would first off like to acknowledge that, and I would like to thank you for making this effort to be with us so early in the morning. So thank you.
Well, you're a wonderful way to start the day.
All right. So tell us about your journey to being an author on a subject as difficult as what you wrote.
I myself am a breast cancer survivor, although mine was minor, if cancer can ever be minor. It was very small. It came out in a biopsy. And so when I went for the lumpectomy, they literally couldn't find it. But I still had radiation and I had after treatment and no chemo. But I realized after that happened what a shock it was. I had worked with the American Cancer Society for so long that it was kind of like the old saying, I gave at the office. I mean, it never occurred to me. There was no cancer in my family. It just never occurred to me that I could be diagnosed with cancer. So I realized how fortunate I had been. And I thought about, I would go in for radiation and I would see these women coming in who, I mean, mine, it took longer to change my clothes than actually to have the treatment. And I would see these women talking about having had months of chemotherapy before the radiation. And I realized I was very, very lucky. And so I wanted to find a way to share that good fortune with others and help them learn from what I had realized the hard way.
So that's it's quite interesting. I briefly worked with the Indian Cancer Society, and it was quite a conversation in that office that when you work so closely with cancer, it tends to find a way in you as well. Uh, and that's rather poignant, isn't it?
It is, and you hear the stories and you laugh and you cry at the same time
Mm,
as your interviewee. It's in some ways it's
yes.
unprofessional, and in some ways it's what they need.
Yeah, and who would have thought cancer would be infectious? Um, well, but be that as it may, take us down the path of that journey of what did you, why did you think that your experience needs to be channeled into a book? Why writing a book?
I think it was because so many of the people that I met, and I met a number of them. The American Cancer Society has something called Hope Lodge, and it's free lodging for people from out of town who come to Boston for advanced treatment. And I had met so many people there whose stories were just breathtaking, that I just felt that they were sharing with me stories about things they hadn't known when they got into it. And it struck me that sharing those stories would be the most useful thing that I could do to spread the word and help people who had not been there before.
Indeed. I think story sharing is a healing process as well, in as much as it is absolutely essential. I think it is fundamental to us, to our existence, that we are able to tell our stories and somebody is able to listen to them. I think it is the very reason why we have conversations with gentle warriors as well. So I saw that you were smiling and you mentioned how you love the name. And the process of writing the book or collecting these stories would have changed you as a person.
Mm.
Could you take us a little bit through who you were and who you became through that process?
Well, I have been a very busy professional in my career and traveled a lot and didn't really make time for that kind of listening and giving back. And what I realized, and it was in the middle of the Great Recession, what we call the Great Recession here, and my work had slowed down. And I thought, well, I need to be doing something that is productive and is giving back. And that's really what led me into these conversations. And I have to say that they were stunning. I mean, they not only make you realize how fortunate you are, but they make you realize how many people around you are going through these kinds of traumas, and they really are traumas, and you don't even realize it. And so it was a way of reaching out, not only to the greater caregiving world, but also within my community,
Mm.
doing things that I had not been able to do when I was doing so much traveling.
I can only imagine, and I think it is good to have people like yourself, authors, who take on this responsibility and who share the stories of others who may not be able to tell their stories. And but I was very intrigued by the title of your book. Why did you choose the title? What is it
What
about
was
Chin Up?
what was interesting was the title, Things I Wish I'd Known, really came from a common theme that so many of the
Mm,
caregivers shared with me, things that they
mm,
learned the hard way. And the concept of chin up, as you'll see when we go through a framework that I'm offering up, was that there are a number of ways that people can either take it on the chin, meaning learning the hard way, or they can find ways to organize themselves and their lives and their caregiving in a way that allows them to be chin up and to bring some normalcy back into their lives while they are caregiving and beyond.
Interesting you should say that, because just earlier today I was doing some research around preventive healthcare and insurance in India. And there was a comment that somebody made, which is, it is so hard to plan and prepare and be able to offer preventive care, especially in India. We just keep thinking that some things will happen to others, they will never happen to us.
Been there, done that.
So, With that, I am going to request I'm so grateful that you made the time to put together a set of slides to take us through them. And I'm going to request Dishari to help you with the slides. Dishari, and over to you.
There we are. It's wonderful to be with all of you this morning. And I want to say I am not here to tell you how to give care. You're becoming experts in that yourselves. I'm really here to share my research, to share my conversations. And what struck me as the common factors that came out in terms of lessons people learned. And I think one of the most important lessons for me was how candid people were and how much they wanted to be heard. And so many of the caregivers said they felt like it was a therapy session because they had had so little opportunity to be heard and for people to really express the hardships and the joys that they were getting out of their experience. And so the conversations really allowed people to feel as though they were becoming whole through those conversations that we had. On the next slide, you'll see some examples of the patients that were the subjects of caregiving. And what's important to know is that not only do patients come in all sizes, shapes, and ages, but their caregivers do as well. The people you are looking at, this lovely young man, Oliver, in the upper left of the slide, was 11 years old and he was a soccer star. And that was a celebration of one of their victories. And he was suddenly diagnosed and he died within a day and a half. So his family was just stunned. Barbara, in the middle, was a corporate executive and she experienced inflammatory breast cancer. I met her at Hope Lodge. She had very difficult treatment. For any of you who know that disease, it is an incredibly challenging disease. It changed her life, but she is now thriving. It's wonderful to see. This lovely little girl on the right had aggressive leukemia. She was diagnosed as a baby, and she spent most of her life in one of our teaching hospitals in Boston before she died at age 4, before her 4th birthday. And finally, the picture at the bottom, Steve and his kids. Steve had had a couple of different kinds of cancer and they had damaged his lungs. And this is a picture of the youngest caregivers celebrating the fact that he had just gotten on a transplant list to get a new lung. So this is just an example of the kinds of people that I talked with or were talking about. And what's important to my database is that in the United States, there are laws that prevent you from sharing healthcare information. And so I had to do my research essentially through networking. I sent emails to friends and they sent them to friends. And I had one interviewee who actually got information about my research through several email chains. She wrote to one friend or someone got my notice, sent it to a friend in another state, who sent it to a friend in yet another state. And this email bounced around until this woman received it. And it turned out she lived 10-minute drive from my home. It's just ironic. I never would have found her. So in some ways, this book is also a tribute to all of the people who shared the information and made it possible to reach all of these folks. And as I indicated, or was indicated in the introduction, I had 101 formal interviews in 19 of the American states, which is about a third of our states. There were 120 recipients of care ages 2 to 92. They had 40 different cancer diagnoses, many potentially fatal, and the care episodes ranged from a day and a half to 24 years and counting. And many more of those conversations took place at community events, on boards of directors that I served, and in my own community. On the next slide, you'll see that our key topics for today are very simple. I'm going to talk just a little about what it is, what caregiving is, and who's doing it. Then I'm going to talk about and give you frameworks for thinking about caregiving roles and issues you'll face. And I'm hoping that those two frameworks will give you a foundation for local conversations and for conversations with Caregiver Satis. On the next page, I'm sure you'll wonder why I'm showing you a fireman, although in this proper day and age, I guess we call them fire people. I have two neighbors, both of whom are firemen. What's important is Chuck's mom. Chuck was one of the patients who died. And her comment, I think she had lost two sons. And her comment was, why do people love firemen? They love firemen because when everyone else is running out of a burning building, they are running in. It's easier to run away, but caregivers are running into the burning building. Other people care, but they don't know what to do, so they run away. Some statistics show that caregivers, in fact, are putting their lives at risk, and they can shorten their own lives by as much as 10 years if they don't take care of themselves while they are taking care of someone else. It's easy to say, take care of yourself, but it's very hard to do. Everyone needs an engaged caregiver. I have a friend, Kathy, who now is about age 50, and she is suffering from brain and bone cancer metastases from her original breast cancer. It was diagnosed over 15 years ago, and she describes herself as dying from the inside out. She's struggling, not only because she's in such constant pain and can't do many of the things she used to do, including, by the way, driving herself an hour to treatment when she needed it to a world-class hospital. But she's also struggled because her husband and her two adolescent daughters were in denial. She's been trying to prepare them for what is inevitably going to come. At the same time, she struggles to prolong her life. Her husband has disconnected her from her friends who would ask if they needed help. And he would say, no, we're fine. She truly needs a caregiving partner who will be a partner and not act like an ostrich with his head under the ground. She needs to have conversations about her reality in order to manage their expectations. But the fact that they are in denial has made her more lonely and more anxious. Amazingly, he had an unrelated heart attack along the way, and she ended up being not only a caregiver to herself, but a caregiver to him. Not easy. On the next slide, you'll see just a quick overview of a few of the issues that I will share in more detail in a moment. There are a number of roles that different people different kinds of players may experience and may need to take on. And we'll talk about those. There's the issue of information, who needs what. It's the issue of knowing what help you'll need and where to find it. And it's ironic because caregiving, while it may be unexpected and usually is unexpected in the case of cancer, nevertheless, it requires planning. On the next page, you'll see that expectations really need to be managed. First of all, what is the outcome that we're expecting from treatment? Is the goal what's called NED, no evidence of disease? We hesitate to call it a cure, but it's no evidence of disease. Or is it comfort care? Is it possible that the patient may die? And that's a really mixed issue because some people don't want to know and have difficulty dealing with the fact that a cancer could be terminal. There are issues of advocacy. There are issues of seeking partners on the medical team. There are issues about who wants what information. And of course, the medical team is your most reliable and accurate source of information if you can build the right relationships. Trusting your instincts is critically important because it will tell you whether, in fact, things are going well. And finally, there's the issue of letting others help. And one of the issues that many caregivers had real difficulties with was letting others in and acknowledging that, in fact, they needed help. On the next page, you'll see that you're not alone in caregiving. Today, there are fewer people cared for in the hospitals, at least in our country. And so people at home tend to be sicker and require different kinds of care. My sister-in-law, Judy, says it's less what her husband did for her during her experience with breast cancer, and more that he was just there in what they called the lost year. And at the other extreme, there was Artie's daughter-in-law. She cared for him in their home as he underwent treatment, and she did everything from taking him to medical appointments and sharing information to literally changing his diapers before he died. Diversity is a really important issue for those of you who have been to the beach and have beaches where there are beautiful shells. What you'll see is whether it's seashells or leaves, cancer is a sneaky predator. It appears in different forms, in different people, and in every person in treatment for even the most common cancers. Cancer is a disease of one or two cells going haywire and all of a sudden growing uncontrollably. I have a good friend who, when she's now in her late 70s, when she was a young mother, she experienced breast cancer, had a mastectomy, chemotherapy, radiation, the whole thing. And 28 years later, she thought she had appendicitis. And it took multiple visits before they discovered, yeah, she had something in her pancreas, but it was breast cancer cells. And it was the same cells that had caused her breast cancer 28 years before. So, I look at my own cancer, I'm 20 years out, 21 years out, and I look at her and I say, okay, Deb, don't get cocky because it may just never be over. But in the United States, the statistics show that 1 in 2 men and 1 in 3 women will have cancer during their lifetimes. 75% of American families are affected by cancer in one way or another. And what that means is there are over 1.5 million new American cancer cases every year, over half of whom are cared for by a family member or a close friend. And so in the last 10 years, that means that over 8 million new caregivers have emerged in our country. On the next page, we'll talk about advocacy, you as an advocate. And as you turn to the next page, which we will, we want to talk about why your advocacy matters. Next page. Dishari? Okay, thank you. You'll see the difference between a thoroughbred horse and a zebra. Doctors will tell you, we aren't looking for zebras. We're trained to look for horses. We're trained to look for the more common things like upper respiratory infections or pulled muscles or run-of-the-mill headaches. A zebra is the term that we use to refer to an unusual or rare cancer that is seen infrequently. It may not have what we call a gold standard treatment yet. And interestingly, different medical zebras occurred in over 15% of the caregivers that I interviewed. The caregivers shared with me that delays in diagnosing those cancers stem from a number of places, and it's important to understand these. The earliest symptoms may look like a common everyday condition, and so the patient may brush them off and say, oh, it's just a cold, oh, it's just an ache, and not seek medical attention. And some patients may be symptom-free with an advanced, rare, or more common cancer found during an unrelated medical visit for another reason. Many physicians are trained to follow a linear diagnostic process that they learned in medical school and that insurers endorse. Seek the causes among the most common ailments. Seek the horses before testing for the more unusual zebras. Physicians may also tend to discount symptoms that are suggestive of cancer because of certain things like the patient's age. Well, it doesn't happen in patients this young. It's typical of an older patient. Take the case of Tim. Tim was an otherwise healthy 42-year-old man who had been having severe abdominal pain. He received nearly a year of treatment with antibiotics because his PCP, his primary care physician, diagnosed him with a recurring urinary tract infection, despite the fact that men rarely get those here. After 9 months with no improvement, Tim and his wife began pressing for more rigorous relief for his pain. This is a form of advocacy. The subsequent long list of referrals and scans led to the diagnosis of a fairly common abdominal condition. The doctor said, well, this is usually benign, and the only way to repair it is a relative simple surgery that is not a big deal. Yet when Tim's surgeon opened him up, expecting the simple surgery he had described, he discovered that the diagnostic delays of nearly a year had allowed what's called a mucinous adenocarcinoma, a non-tumorous cancer, to spread throughout Tim's entire abdomen. Despite surgeries, repeated chemotherapy, radiation, and encouraging messages from the medical team, he died almost 4 years after his initial symptoms. His wife, Sarah, his caregiver, never realized that he might die. And the medical team's explanation, well, we weren't looking for zebras, was little consolation to his widow. So doctors are more likely to diagnose symptoms as something common. And let me give you a few examples. Doug was a high school athlete, and he was having joint and muscle pain. The doctor diagnosed him with a sports injury. And what he thought was a sports injury turned out to be Ewing's sarcoma, a bone cancer, which led to his death 2 years later. Now, Jeff, who was only 13, was more fortunate. He had been living with chronic asthma, and Jeff began to experience night sweats, weight loss, vomiting, and sleeping problems. It took his doctors nearly 6 months to determine that his symptoms were, in fact, those of Hodgkin's lymphoma. Because his mother advocated for him and pressed for more attention, Jeff is now cancer-free at age 20. Then there was Becky. Becky had undergone 2 rounds of antibiotic treatment for what was diagnosed as an upper respiratory infection. Finally, after pressing the medical team, she got a diagnosis of inoperable stage 3 mesothelioma, an asbestos-caused disease. And she consulted with a world-renowned cancer center. They revised the diagnosis, removed 1 lung, and now she is a 14-year survivor of an often fatal disease. And finally, 2 other examples. Rob was the father of 2, and he had chronic snoring, and it led to 2 years of repeated visits to doctors, sleep studies, a machine to force air into his airways at night, and specialized referrals, until he was diagnosed with chondroicarcinoma, a cancer so rare that only 300 people per year are diagnosed in this country. Because they advocated for him and pressed the system, Rob has survived and is doing well. And finally, in these examples, there's teenager Michael. Michael had persistent colds, sore throat, and swollen glands. And his doctor said, well, you know, his high school schedule is very busy. And so he's just pushing himself. 6 months and many referrals later, he was diagnosed with metastasized medullary thyroid carcinoma, a cancer so rare that even the specialist who finally treated him had never seen this form of cancer in a 17-year-old male. His cancer is not considered curable, and this goes back to the issue of setting expectations, and he will be living with cancer as a chronic disease, being in treatment for the rest of his life. You have to push when the diagnosis is dragging out or you think something is being missed. Several of these patients did survive, but getting a diagnosis was a battle. My own mammography experience was an example of that, even though my cancer started out to be minor. I went for my mammogram and I got a call back in about 10 days saying, we need you to come back for a reshoot. And I said, when can you do it? And they said, oh, in about another 10 days. That was now 3 weeks from the original shoot. I went back, and then 2 weeks later, I get a phone call saying, we need you to come back for a reshoot. And I asked, when can you do it? And the person on the phone said, well, we could arrange it in about another 2 weeks. Well, I knew too much about cancer to accept that. So I basically said, can I speak to your manager? The manager got on the phone and said, well, the only way we could do it is if I came in early. And I said, wonderful, what day would you like to do it? It was my own experience in having to push the system and be an advocate for myself. It is a joint responsibility between the medical team and the caregiver and the patient. I had one cancer expert who said, doctors are often untrained to look for the less common diagnoses. So patients are forced into the tough position of battling the fears and emotions associated with their illnesses, while at the same time pressing doctors to do their jobs better. No PCP, primary care physician, can be expected to recognize every rare cancer immediately. But every healthcare provider should have what I call a zebra bypass procedure to expedite multi-pronged testing simultaneously when seemingly common symptoms defy care. Call a zebra hunt if you are not getting the attention that you need. And don't stop pressing for a second pathologist or a second radiologist to review your lab results and your scans. And don't stop pressing until they find the cause. Accelerating zebra hunts is a critical issue because many cancers travel incognito. They're hiding. And regardless of the symptoms, whether a minor condition and very treatable one is discovered or a very serious one, cancer patients, caregivers, and their healthcare providers are critical members of the team. And every cancer is more successfully treated when diagnosed earlier rather than later. Later means it's more advanced and it may have spread to distant organs where it is less treatable. So let me share with you, first of all, on the next page, a framework for thinking about your own role as a caregiver. On the next page, you'll see a schematic. The schematic shows you several different roles that could, in the end, generate stress. There is a challenge to arrange and plan, and you already have busy lives. And now you're having to combine your already busy life, your day-to-day issues, with making sure that you're keeping track of various appointments. You can schedule transportation to those appointments. You may have child schooling and child care, food shopping, and so on that need to be adjusted and for which you may need help. It's best to create a community of helpers. Remember that people want to help. It makes them feel good. So the challenge is to figure out how, when, and where to let them help. In this country, there are actually coordination systems where you can sign up and indicate what your meal choices are. What are things that your family is allergic to? What help people can give you. And what we've also learned from these caregivers is when you are coordinating help, find ways to make it easy. I had one caregiver who had little bags of goodies that she would leave outside the door, so that when someone dropped something off or did her a favor, they could just pick up a bag of goodies and not feel like they were interrupting the family. She also had a cooler with ice in it, and she left it outside the door so that if people were leaving a meal, they could leave it, again, without feeling as though they would be bothering the family. The second role, which I've talked a lot about so far, is advocating, trusting your instincts and pressing the medical team if things aren't going well. That also means, and I'll say more about this later, if you are not getting the help you need, thinking about maybe I need a different medical team. The third important role is boosting your loved one's spirits, especially during treatment. This means finding things to look forward to, favorite movies, music, yoga, puzzles that you can do together, even a massage, and orchestrating activities that will bring happiness and joy so that the patient can enjoy today and worry less about the future. The Chief Information Officer is a conduit of information. You are the focal point and certainly want to ask the medical team what to expect, what to watch for, and what to do if unexpected setbacks occur. On information, I ran into two kinds of extremes. Tiffany had been diagnosed with serious colorectal cancer at age 34 with young children. She wanted every piece of information she could get her hands on. I mean, she was what we call an information junkie. She just couldn't stop. On the other hand, there was Mike, and I'll be talking about Mike at a couple of points in this discussion. Mike had his wife taking notes, and he said, "Don't bother me with the information. What I need to know is that you have it, that you trust it, that it's coming from good sources." And she even recorded medical conversations on her phone. She got permission from the doctor, but they had a relationship with their medical team where she could record conversations and she could drop into his office, the doctor's office, to ask questions. Critically important. And one night, Mike woke up and he was feeling very anxious, and his wife pulled out her phone and replayed a piece of the conversation that they had had with the doctor earlier that day. And it allowed him to relax and to feel soothed about what was going on. Decision support is part of the role that she was preparing for. It's a role that requires information and a good relationship. And the most critical decisions that you will be called upon to make or to help make is, first of all, when to start palliative care. And let me be very clear. Palliative care is for quality of life. It is not hospice care, which is care at the end of life. Palliative care is mostly recommended from the moment of diagnosis. It's a way of making certain that you are looking out for symptoms that are causing discomfort and doing everything possible to maximize the comfort of your loved one. Another critical decision is whether to participate in a clinical trial. Clinical trials can sometimes prevent you from participating in other kinds of treatment. So it's very important to understand from the medical team what are the advantages and what are the disadvantages of that kind of participation. And finally, when is further treatment not going to make a difference in the length of life and may in fact impair the quality of life? So even there, you need to pay attention. I had a neighbor whose wife was experiencing lung cancer, and she had not been a smoker. And he found that hospice care in the home was missing the fact that they needed to be turning her regularly, and she was getting bed sores because they were not. And so he had to pay attention and had to advocate for her to make certain that the hospice care was dealing with what needed to be handled. If we go to the next slide, you'll see that stress has become self-care. And what we found was, again, that caregivers can shorten their own lives inadvertently if they fail to care for themselves. So what did caregivers do? We had one who was a competitive biker. He rode his bike in races. And initially, he was caring for his wife. And initially, his mother-in-law was very critical of the fact that he was going out and riding his bike, until she saw him in a race before and after the race and came to understand that it was a stress reliever. Some people participated in a knitting group or a quilting group. Some people went walking or running, yoga, meditation. We had one who played in a band, and they would get together in his garage a couple of times each week and play in the band. Sometimes it was just going out with old friends, but it was always getting out of the house or hospital every day to do something unrelated to cancer. On the next page, you'll find that when you're carrying out these roles, you'll encounter 4 important issues. The first is control. And one of the things that was truly common and striking was how people described the images that came to mind when they got their diagnoses. The images were always violent and reflected their feelings of complete loss of control. They were images of a car crash or a train wreck or an earthquake or falling overboard from a ship. And they led them into, for any of you who are familiar with Kubler-Ross's framework, shock, anger, rejection, and acceptance. It led many people into that sequence of thoughts. Initially, the shock being loss of control. Conscious choices really have to be made so that even though we can't control events that overtake us, we can influence how we respond. So don't try to take over. I mean, you want to let the person with cancer call the shots as much as possible. And my biking friend caregiver described their process. He and Mindy were laser focused, like a horse with blinders on. He said it gave us a goal and guided us toward things that we could control. So when I asked him what were those things, he and many others said, well, first of all, it was information to allow good decisions. Support, individually or in a group. And I know Caregiver Satis has a number of ways that you can get that support. Simple logistics, putting 2 sets of sheets on the bed so that if the patient got sick in the middle of the night or couldn't get to the bathroom quickly enough, there was another set of sheets easily accessible. Having water bottles near the bed, having the cooler outside the door of the house. Another one was how financial issues will be handled. And as most of you know, financial issues are extraordinarily difficult. There's the cost of treatment with or without insurance. There is the loss of employment potentially, or the loss of income if you have to take time off of your employment. decisions about treatments, whether to do clinical trials, how your children will be cared for when backups are needed, and for some, how and when they would die. One of my neighbors had what I call Bill's World Tour. He was a public health expert who had traveled to a variety of countries around the world. He knew he was dying, and he decided what he was going to do was go back to the countries, some of them in Africa, where he had networks of people who he wanted to say thank you to. And so his world tour was saying thank you and saying goodbye. And then there was Artie. Artie died at home in his bed with his 2 grandchildren at his side, watching a baseball game on television, and with his family toasting him with a good cold beer. And finally, there was Ben's dad, who was in a reclining chair next to a lake in his backyard, watching an eagle fly over the lake. On the next slide, you'll see the second issue, hope. And hope is ever changing. It's a belief in the possible, even when the prognosis is grim. One part of that is having realistic goals. And as I told you, Tim's wife, Sarah, never confronted the fact that he might die, so her goals were unrealistic. The goal could be turning cancer into a chronic disease that you can live with. We've talked about palliative care from day one. And what's really important in hope is making the most of every day while your loved one is alive. The commitment to give a loved one joy and to fight through the fear is what makes us human. It's also what makes it possible to go on and creates hope in the face of desperate situations. And as a rather crude example of joy, I met a woman in my own community who was caring for a friend, and her friend had had a mastectomy. And so my friend said, well, let's go do something about that. And after her mastectomy, they went to the store and they bought a large sponge and stuck it in her bra. This is before she had dealt with what she was going to do. And what was very funny was the 2 of them were laughing their heads off. They were literally doubled over laughing in the aisle of the store. And the people waiting on them could not figure out what was so funny about a sponge. There's also the case of Carl. Carl lost most of one leg to an unexpected cancer, and he was a swimmer. He felt he would never again engage in his favorite pastime, swimming. Out of love, his wife challenged him directly to pick himself up and go rediscover his passion. And the way she described it, she said, I pushed Carl to know that he did not need 2 legs to swim. He had been a very good swimmer, and it was so normalizing for him. I told him that all he needed was his torso and his arms. He couldn't control losing his leg, but he can control what he does with the rest of him. We came with our own optimism. Instinctively, we wanted to get on with it and not get stuck. And this is a combination of control and hope. Pushing back and challenging him to take charge of the rest of his life was an important piece of living each day. I want to talk on the prior slide one more thing about hope. Mike, and I'm going to talk about Mike a couple of times. Mike was a vigorous 58 when diagnosed with pancreatic cancer in 1997. At the outset, he was given 6 weeks to live. When he asked his doctor, what should he do? The doctor said, either do nothing or give it hell. And Mike's wife, Carol, said, well, he sure gave it the second option. And he lived for 27 months, which was a real miracle at that point in time. And while he fought the disease, he was helped by several clinical trials that sustained his life and palliative care that minimized his time in the hospital and his discomfort. What was important about Mike and Carol is that they engaged their young adult children in caregiving. They had one son who cooked gourmet dishes for him, even though Mike had no appetite. He often helped Mike dress, and he even hired a van to take the family for a surprise getaway weekend for the entire family. The other son would watch sports with him, briefing him on the scores if he dozed off. Their daughter brought her first child to see him every day, whether at home or in the hospital. Carol says, it was inspiring and impressive. And I think when Mike would announce, contrary to all evidence, that he was the luckiest man alive, he was marveling in being able to witness the unselfishness of his young adult children. One day I asked our daughter, she said, if spending so much time with us was putting a strain on her family. And her answer was, in a perfect world, we would not be there as much, but it's not a perfect world. Finally, in 1999, 27 months in, Mike died at home with a view of the ocean, surrounded by his family, anxiety and pain-free. Mike's wife describes it as a victory to this day, a victory of love, even in the face of her husband's inevitable death. Sharing her story shares her hope and reinforcement for her support for pancreatic cancer research, and it inspires other people. And what I found was, it was amazing how many people, how many caregivers, after the fact, had gotten engaged in cancer support and fundraising and research activities. And Carol is one of the best. Moving to the next slide, isolation. Isolation is a huge risk, partly because some caregivers are stoics. We're okay, we can handle that. Well, that adds to stress. Time, thinking you're too busy to accept help and feeling like you're conserving limited time. Feelings, for some people, it feels risky talking about it, even to each other. And acknowledging it and living with your feelings is critically important. Carol was surprised when Mike befriended the parking staff at his world-class medical center. Why did he do that? He said, I'll be seeing a lot of them, so they might as well be my friends. Another important observation about feelings was that when Doug died at age 17 of Ewing sarcoma, a bone cancer, he died surrounded by his family and his schoolmates. His mother didn't ask, how are you feeling? She asked, what are you thinking? Finally, pullaways. And I think the most extreme pullaway was Tyra, who had been diagnosed with breast cancer and had a mastectomy, chemo, and radiation at age 27. Her fiance walked away, and she learned that he was not her loving partner for life, let alone during this crisis. Why do people pull away? Partly they're afraid of looking in the mirror at their own mortality, and partly they simply don't know what to say and what to do. So how can you overcome pullaways? Invite people to your home. Talk about things other than cancer. engage in group activities, games, reading groups, watching movies, whatever, but something that will take your mind off of your cancer, because you are not your cancer. You are a person. Finally, on the next page, normalcy. Everything normal has changed, and it's important to remind your loved one that you are not your cancer and you are not defined solely by cancer. Your vision of life beyond cancer is worth fighting for, even if it will be shorter than you had hoped. And you will not be alone. That may mean defining a new normal. And there were several active caregivers who said a new normal meant, for instance, Sharon's sister saying, just treat me as you treated me before. Don't treat me, the caregiver, any differently, and don't treat my loved one any differently. And then there was Jen's husband, he was the caregiver, who said, could somebody just not give me that look? You know that look. That look is, oh, I'm so sorry. Oh, you're having such a hard time. Seeing yourselves as active partners with the healthcare team rather than a passive observer is critically important to your loved one and to creating a new normalcy. And creating joy every day while you have it and while you can have it is important. Samantha's mom said, once you've been through a tough and long treatment period, you never believe you're out of the woods, but nevertheless, creating a new normalcy is what matters. So, on the next slide, caregivers live in the environment that I've labeled CHIN: control, normalcy, control, hope, isolation, and normalcy. And in that environment, the aftermath was often the hardest part. And that's because during the busiest times, there were lots of things that were occupying the caregiver's time and thoughts. Afterward, the lack of structure can feel overwhelming, especially if your patient has died. Many had dreams, seeing their loved one at the foot of the bed, literally talking to them. And that person was always alive, well, smiling, and assuring the caregiver that they were okay. I had a female physician who told me that when her husband had gone into cardiac arrest and was on the table for an MRI scan, she actually saw him rising out of his body into a bright light and reassuring her that he was okay and not to resuscitate him. And believe it or not, that vision has given her strength over the years. After his wife died, and this is an odd one, Ned was about to phone a woman to ask her on a date, when inexplicably behind him, a picture fell off the wall. It was inexplicable, but he was so shaken, he never made the phone call. And finally, believe it or not, Sarah, Tim's wife, is getting married again. She's still heartbroken that he died. And she says she can't understand why her friends keep saying, but you should be over it by now. And she says, I'll never be over it, but I'm in love again. And she's starting to let herself be happy. And I know this will sound odd. She's marrying their social worker. It's tempting to second guess yourself when you're living in chin world, but it doesn't help you heal. Finally, on the next slide, the aftermath is taking it on the chin taking it hard, to being chin up. First of all, don't own outcomes you can't control. Carol could have said, I'm a failed caregiver, but instead she said, Mike far outlived expectations, and we had good times while he was doing so. Peaceful pastimes, as I said, yoga, meditation, bird watching, fishing. I had a friend on creative projects who actually did classes at Hope Lodge, where there were both caregivers and patients living there for free during their treatments. She did crafts projects, writing, performing music, writing poetry. She had a photography project and people were doing journaling. And those kinds of personal projects allow you to really get your feet on the ground and get some sense of accomplishment, peace, and relaxation. Giving back and fighting back were really important. Whether it was Tommy's sister, Doug's mom, Patty's family. Patty had 22 people in her family who had experienced cancer, and both of her parents died of cancer. She has been incredibly active in fundraising for advocacy with our governmental structures to make certain that money is going into cancer research. And finally, unstructured, unplanned travel, going to soothing places and engaging in soothing activities with company who will be soothing. So finally, on our last slide, we simply raise the question, are there other issues that you're facing? And are there ways that Caregiver Sathi can help? They're a critical resource for each of you and all of you. Thank you for your time. I hope this makes a difference for you.
While I invite our audience to share their questions, I have to say that listening to all those stories was rather moving, and I could actually visualize some of the people that you told us about. And I couldn't help think that, there are so many hundreds and thousands of stories here. And how lovely would it be that just inspired by you, if each one of us could go and collect some of these stories and encourage some of these stories to be told, either on our platform or on through our podcast, or maybe somebody will write a book.
It's that important, and what you will find is that caregivers want to be heard. I had one young woman who I asked, and this goes back to caregiver stress. She had, I think, 3 siblings, and 2 of them brothers, 1 a sister, and they all were very happy to have her doing the caregiving for their father. Thank you very much. And I asked her, did any of your siblings ever ask you, how are you doing, as he was dying of mesothelioma? And she started to cry.
Yeah.
And she said, no, this is the first time anyone has cared to ask that question. So it will help the people that you talk with and from whom you gather the stories.
Yeah, so I'm going to invite anyone who is here and has heard Deborah today. And if you have any questions, please just raise your hand and we'll invite you to show up and ask your question. And while people gather their wits and their questions, let me ask you some of the questions that came in at the time of the registration. So I think one of the shared experiences, especially when there is cancer, is that there is so much dread around the illness, right? When you discover somebody has, what do you ask a caregiver? What can you say or what can you not say? How can you support the caregiver?
And I think it's a common question. And I think the answer, I mean, there's no clean, easy answer, but the approach is to gather information, to take a deep breath, and to say, okay, I'm riding this bucking horse and I'm going to figure it out because I've always figured things out before. I mean, cancer care is a process of figuring it out as you go, improvising, learning, and networking with other people who have been through it. But your medical team, and particularly the oncology nurses, can be incredibly useful as sources of information.
Yeah. I think one of the things that has helped me a lot is to simply acknowledge that I'm feeling helpless, you know, to
Yes.
just say to the caregiver, saying, I'm out of depth here. I'm sorry. I don't know what to do. Let's figure this out together.
And not knowing what to do and learning how to live with that is part of the answer to that question.
Yeah. Yeah. So, there's a question that is there a way to reduce cases by creating awareness for prevention of cancer? Yes, of course. There is a lot of, you know, diagnostics and probably, but we are such a large population and we are constantly increasing, and there are different types of things coming. My personal view on that is slightly different, but I'd like to hear what you would have to say, Deborah.
Well, what is difficult, and particularly with the pandemic, the medical systems have been stressed. People are not, at least here, are not getting the kinds of screening that would allow identifying early cancer. So mammograms are down, much of the testing is down. There are supply chain problems in getting some of the dyes and chemicals that are needed for some of those tests. And so it is critically important to just keep pressing and to keep attempting to get attention now. And I guess the only suggestion I can make is pay attention to your body, pay attention to get your loved ones to pay attention to their bodies, do the kinds of things like reducing smoking, and I know that may be difficult for many, and worrying about diet and exercise and all those boring lifestyle things that they tell you to do, as a way of at least putting some sense of control back into your situation.
Thank you for saying that. I think looking at prevention, managing a healthy lifestyle is the best that we can do. When I'm my cynical best, I am thinking, well, if it wouldn't be cancer, it could be something else, right? It was
And
COVID.
it's always going to be something.
Yeah, and if it wasn't COVID-19, then it is Omicron or whatever else. And,
Whatever it is.
life will throw curved balls at us. And I don't think we can say that let's stop those curved balls. We can
Right.
just say, are we going to take the lemons and make some martini out of it?
Yes.
Yeah.
Yes.
So, looking forward to any questions. Lots and lots of our volunteers here. I'm delighted to see some names. Would any of you have any questions? I'm hoping that Deborah's conversation and the beautiful stories of hope and of inspiration that she has collected, irrespective of how long somebody lived, I think they are stories of resilience and hope, and very inspiring. So we are inspired to go and collect because there are so many stories around us. I hope that those who are listening to us right now or will listen to us later because we're on all the platforms. And should people listen to this, I hope that people will collect some of these stories. People will encourage the others to come and share their stories on our platform or on our podcast. And hopefully, there will be many, many authors as well.
And I have to just share without interfering. I have to just share that in collecting those stories, you will be enriched.
Yeah. Yeah. Thank you for saying that. It is not just for the stories. Yes. Um, I'm going to once again acknowledge Deborah for making the effort, the incredible amount of effort as a run up to this program and early morning and joining us and sharing such a big part of you. Thank you very much. I am delighted that thanks to the pandemic, we now have this facility that we can connect across time zones and change the shape of caregiving.
Thank you.
Thank you. Thank you very much to all of you who made the effort to be here to listen to us. And thank you. One last option. Anyone, any questions? If not, then going, gone. Uh, have a lovely evening, people. Let's make this a world for caregivers. Let's acknowledge caregiving as the very essence of humanity. So, thank you. And please reach out to the caregivers in your networks. Have a lovely Friday evening and a great weekend. Thank you.
Thank you.